We are very honored at Cambio de Colores to have Dr. Purnell giving our keynote speaker in the afternoon. Dr. Purnell is an assistant professor in the George Warren Brown School of Social Work at Washington University in St. Louis. He's trained in both applied psychology and public health. Dr. Purnell leads the For the Sake of All projects, a multidisciplinary civic education and mobilization initiative highlighting the regional significance of disparities in health and life outcomes from African Americans in St. Louis, Missouri. The project and a report by the same name released in May 2014, having a critical resource in the wake of the unrest that followed the fatal shooting of Michael Brown in the suburban St. Louis city of Ferguson in August of that same year. Several of the report recommendations are included among the signature call to action of the Ferguson Commission appointed by the Missouri governor. Dr. Purnell and his team and partners have been instrumental in convening cross-sector stakeholders for strategic responses to disparities in health, education, and economic status. How you will imagine Dr. Purnell's work has been published in multiple journals, and he told me that he did not want me to read his whole bio, but this part I found fascinating. Significant interest in For the Sake of All has led to coverage by NPR, The Washington Post, the Bloomberg Business, the Maclean in Canada, the Korean Times in Korea, the Joe Madison Show in Sirius Radio, Vox.com, and the St. Louis Post-Dispatch. If you all help me welcome Dr. Purnell to the stage.
Thank you very much. It's a pleasure to be with you this afternoon. I'm going to jump right into the presentation on a project called For the Sake of All that I've been working on since March of 2013. And I want to begin, hopefully, with some definitions of terms that I'm going to be using in this presentation. The first is the social determinants of health. And this first definition comes from the World Health Organization. The social determinants of health are the conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. And those forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. So as I said, that comes from WHO. The Robert Wood Johnson Foundation has a pithier way of talking about the social determinants of health. Health happens where we live, learn, work, and play. What's important about both of these definitions is that they don't talk just about health care. When most people think about health, their minds go immediately to hospitals and doctors' offices and medications and surgical techniques. But what we know is that health is much more strongly determined by other factors. In fact, the director of the CDC, Thomas Frieden, put together this pyramid to talk about what kinds of factors have the largest impact on health. And a lot of people sometimes are surprised to learn that the smallest impact is actually where we spend most of our time and most of our money when we think about health and healthcare. It's those clinical interventions, counseling people to eat a healthy diet, both of which are necessary but not sufficient to have the largest impact, which is actually down here at the bottom of the pyramid. Socioeconomic factors like poverty, education, housing, and inequality, I would add discrimination, actually have the largest impact on health. They're also the most politically fraught and difficult factors to change, right? And a little further up the pyramid, changing the context. This is kind of the province of behavioral economics, making the healthy choice the easy choice, also has a larger impact than the nearly $1 in $5 we spend in GDP on medical care in the United States. So last April, an economist by the name of Raj Chetty, who generally studies social mobility, economic mobility, put out a paper on the relationship between income and life expectancy in the United States. And really not surprised to learn that how long you live, from a public health perspective, we weren't surprised to learn that how long you live is directly tied to your income. In fact, there's a pretty consistent, what we call gradient in public health, that the more income you have, the longer you can expect to live. What Chetty found, though, was that there was a variation in this relationship across the United States, both for the top and bottom income quartiles, and that the relationship has actually gotten stronger over the past several decades, so that the gap between those who have more and less income has been widening over the past several decades, so that we see almost a 15-year gap in life expectancy between the bottom 1% and the top 1% of men, and almost 10 years of a gap in life expectancy for the bottom 1% and top 1% of women. And that this is distributed differently across the United States, which suggests that we have to have local approaches and local solutions to the things that are driving this disparity in life expectancy. And that's really what For the Sake of All is about, using local data and research evidence to solve local issues of disparity. So when we started back in 2013, we had 4 goals. First, to inform the public about the social determinants of health, as they impact health disparities for African Americans as one of the most vulnerable populations here in the St. Louis region. Second, to present not just the moral or health story, but also to talk about the economic impact of these persistent disparities and the impact of either intervening or failing to intervene on social determinants of health. And trying to tell that story, as the title of the project suggests, with a view to how this impacts everybody in the region, regardless of your race, your ethnicity, your socioeconomic status, that there's a cost, there's a burden that's being borne by the entire St. Louis region by having these disparities exist. And a little fun fact about the title of the project, For the Sake of All, is actually the title of an unfinished musical composition by a famous St. Louisan named Scott Joplin, who's known as the king of ragtime. So if you've ever heard the Maple Leaf Rag or the Entertainer, that's Scott Joplin. And the title For the Sake of All was found with his papers, but we don't have the score. The score was never completed. We thought that that was a good metaphor for the unfinished work we still had to do in the St. Louis region to get to health equity and other kinds of equity in our region. And the final goal was to try and influence the policy agenda around health disparities by taking us beyond the well-worn conversation about medical care and personal responsibility. Medical care and personal responsibility are necessary, but not sufficient to close the kinds of gaps in health and other life outcomes that I'm going to take you through. So we released this report in May of 2014, For the Sake of All, and almost immediately there was quite a bit of reaction to it here locally. That reaction would be amplified a couple of months later when St. Louis became the epicenter of what we now know as Black Lives Matter after the fatal shooting of Michael Brown, not too far from where we're sitting right now. But just to take you through some of the highlights of what we reported in that report, I always tell people that it's a positive thing that these lines are going down and to the right. So these are mortality rates or death rates for African Americans in orange and whites in gray. And it's a good thing that those mortality rates are declining. What concerns us, though, is this persistent gap between these two lines. And we were actually able to estimate in a single year, 2011, how many deaths among African American adults were attributable to 2 social factors, 2 of those social determinants I was talking to you about, education and poverty. So we estimated of the roughly 3,100 deaths that occurred among African American adults 25 years and older in that year, 305 of those deaths attributable to poverty, 263 of those deaths attributable to having less than high school education. And to put that in some local context for folks, we told them that that was enough lives, enough people, to fill over 7 Metrolink cars, which is our light rail public transit system. And people always ask, well, how do you attribute a death to poverty or education? Don't people die of cardiovascular disease or complications due to diabetes? Yes, they do. But we also have several decades of research and data that links these social factors to mortality rates, to death rates. And we're able to estimate what the contribution of those social factors is to death rates. So as I told you, it's not news to us in public health that there is this strong relationship between social factors and health outcomes. This is just one way of showing you a gradient in health outcomes. This is family income along this axis, and this is your relative risk of premature mortality. And you can see that your risk of premature mortality declines at every step up the income ladder. And most people are not surprised to learn that the wealthy have better health outcomes than the poor. They are somewhat surprised to learn that there's this kind of stair-step function where the middle class have better health than the working class have better health than the poor, and the very poorest have the very worst health outcomes. So you could actually graph any number of factors along this axis. This could be education, it could be wealth, it could be even occupation if you were able to rank order occupation, which was done in the British studies and the Whitehall studies. But what we have found is that, I told you that that gap is widening between those who have more and less income. The gap is also widening between those who have more and less education. So this is one analysis between 1990 and 2000. Those who had high school or less education gained no years of life expectancy, 0. Whereas those who had high school or more, or rather any college, had completed any college, gained over a little over a year and a half of life expectancy. This is another one of those relationships where the gap between those who have more and those who have less has been widening over the past several decades. And this is easily the single most famous and cited piece of information from the report. It's been quoted all over the place. This is a map of life expectancy at birth by select zip codes in the St. Louis region. And this is the city of St. Louis. I think it looks like a stomach. This part right here. And this is St. Louis County. And for those of you who aren't from St. Louis, the city of St. Louis and St. Louis County are politically distinct entities. So it isn't as if the city is part of St. Louis County, although that's a lively conversation we're having in the region right now. But these are actually two politically distinct. And it gets even more distinct because there are 91 municipalities in St. Louis County. Highly fragmented regional area. What most people have focused on, though, is this relationship right here. So this is 63106 in North St. Louis City, predominantly African American, low income portion of town, where the life expectancy at birth is 67 years. This is 63105 near my campus at Washington University in an area called Clayton, where the life expectancy at birth is 85. This is an 18-year gap in life expectancy in a geography that's separated by less than 10 miles. So I've begun calling this map the geography of inequality. The upshot of this map is that life and health and the factors that support life and health are not equally distributed in the St. Louis region. And St. Louis isn't alone among major metropolitan areas in that. But I also hasten to add that health and life and the factors that support health and life are not randomly distributed either. This map is the result of conscious policies done on purpose over several decades. So keep that in mind as we look at this next series of maps. This is drilling down on this notion of the geography of inequality. This first map is the percent African American population by zip code in the St. Louis region. Orange is the highest, and you'll have to forgive me, the angle of this, I can't read exactly what those numbers are. It's something like 44 to 90-something%. And light blue is moderate, and dark blue is the lowest at about 1 to 5%. St. Louis, depending on who's counting and which metric you're using, is either the 5th or 6th most segregated major metropolitan area in the country. This is a map of poverty by zip code. Again, where orange is the highest, light blue is moderate, dark blue is the lowest. So those are two social factors that we mapped. These next two are health outcomes. So this is cardiovascular disease mortality, or death rates. Again, orange is the highest, light blue is moderate, dark blue is the lowest, and these are cancer death rates. So the point of these maps is not to tell a causal story. So for my academic friends out here, we're not trying to say that map A causes map B causes C, and so on. The point is, when you overlay these maps on top of each other, notice where the orange stays orange, and the light blue stays light blue, and the dark blue stays dark blue. So further illustrating that health and life are not equally distributed. Now, I talked to you about the fact that medical care and health care is necessary but not sufficient to close the gaps in health outcomes. This pie chart, and if you were taking my class, Health Behavior and Health Promotion, I'd make you guess what these numbers are in this pie chart. I'm not going to make you do that. 10% of the contribution to premature death in the United States is explained by medical care. And remember that we spend almost 1 in every $5 on health care. 1 in 5 of every dollar that churns through the economy in the United States spent on health care. For health outcomes that are poor to middling when you compare us to other advanced industrialized nations of the world, I would add. The biggest slice of this pie is this 40% that has to do with behavioral patterns. And when we talk about behaviors, what we're talking about are things like maintaining a healthy weight, eating a healthy diet, engaging in regular physical activity, refraining from smoking. We know that smoking kills almost 500,000 people every year, just in the United States. #1 preventable cause of death and disease in the world. The problem, though, the cultural problem, when I tell you that this has to do with behavior, is that the American mind goes almost immediately to personal responsibility and individual integrity and bootstraps and pluck and metal and pick your other metaphors. Right? Or as my mother might say, just act right. The problem is that behavior happens in a context. Right? So all my admonitions as a public health professional about 150 minutes of moderate to vigorous physical activity don't mean anything if 39% of African Americans consider their neighborhood to be safe. You're not taking a walk after dinner, you're not sending your children out to play if your neighborhood's not safe. That's not a rational decision. 66% of African Americans who live in the city of St. Louis find it easy to buy healthy foods. So if you have to take 2 buses with 3 children to find a fresh fruit or vegetable, it's going to be hard to eat 5 to 7 fruits and vegetables. Right? This isn't just about personal responsibility. This is about a context that supports behaviors that support health. And the context doesn't always support those behaviors. Case in point. This is a map showing you the availability of quality, nutritious retail foods by census tract in St. Louis. And you want to think about this map and the index that it's based on as the ratio of full-service grocery stores. And in St. Louis, that's places for the St. Louisans in the room. That's places like Schnucks and Dierberg's and Aldi and Trader Joe's, Whole Foods, if you want to spend more money. The ratio of those kinds of outlets to the McDonald's and the Burger Kings and the Taco Bells, right? Orange is poor or no access, light blue is fair access, dark blue is good or high access. So there is a stretch of a street called Olive Boulevard here in St. Louis between another street called Lindbergh and, if you're not from St. Louis, Interstate 64. If you are from St. Louis, Highway 40. If you're deep from St. Louis, Highway 40. That's our little accent. There are 3 Schnucks, 3 Dierbergs, a Trader Joe's that's across the street from one of those Dierbergs, an Aldi, and until recently something called a Fresh Market, which was just expensive food. That's an 8-mile stretch of road with 8 high-quality grocery stores. These are the grocery stores where you can also get your hair cut, do your banking, get a latte from Starbucks. These are get your sushi, full-service grocery stores. And there are parts of our region where there's nothing. Or if there is something, you wouldn't want to eat it. You wouldn't want to buy it. Health, life, the factors that support health and life, not equally distributed, not randomly distributed. Turns out that education is one of the strongest and most consistent predictors of health outcomes that we have. I have a colleague at Virginia Commonwealth, his name's Steve Wolf. He put out a paper a couple of years ago that showed that if we gave everybody the education level of the college educated, we would have saved more lives than all the medical advances combined in the last 20 to 30 years. All the cancer treatments, all the new drugs, all the surgical techniques, just by giving people higher levels of education. This is a map that looks a lot like that first map I showed you in terms of where African Americans live. This is the percent of African American enrollment by zip code, or by school district rather, for St. Louis. And 60 plus years after Brown versus Board of Education, we can still talk about school districts that are 97% African American. And this is a map of high school dropout by zip code, where orange are the highest rates of dropout, light blue's moderate, dark blue's the lowest. We also know, remember I told you that gap is widening between those who have high school or less, some college or more. We know that whites are more likely to have some college or more, African Americans more likely than whites to have high school or less. We know that in 2012, 1 in 10 African American 9th through 12th graders dropped out of school. That was about 2,000 children in that single year. And we know that if you use 3rd grade English language arts as the fairly consistent and strong predictor that it is of later educational outcomes, the number of children on their way to high school dropout in a number of our districts. Education is not a panacea, though. Education is one of those things that's necessary but not sufficient also to close racial gaps. The upshot of this graph, and I always pause when I say this because it's still, every time I talk about this, it still punches me in the gut. The upshot of this graph is an African American woman who's graduated from college or more is still more likely to deliver a baby at low birth weight than a white woman who hasn't graduated from high school. in St. Louis in the 21st century. So education, we get told, is this great equalizer. Just go to school, everything's going to be all right. No. There is still a residual effect of race in systemic and systematic ways, even after an African-American woman who has done everything right. If you're interested in this phenomenon, and it's puzzling, it's bewildering, because we expect higher socioeconomic status. I told you a little while ago, higher the socioeconomic status, the better the health outcomes. That's true in this case. There's a gradient here. African-American women do better with more education, just not as well as white women with the same level of education, right? If you're interested in this, there's a documentary that came out a couple years ago, several years ago now, called Unnatural Causes. And there's an episode of that documentary called When the Bow Breaks that's all about this phenomenon. One of the hypotheses is that it's the stress of racial discrimination and racism that is actually rewiring the stress response, not just for African-American mothers, but for their babies while they're still in utero. And unfortunately, we've got birth outcomes that mirror this disparity. So an African-American infant is 3 times more likely to die before their first birthday than a white infant in both the city of St. Louis and St. Louis County. And we know, among African-American adults, mortality rates for the leading causes of death are also higher. So mortality rates for cancer, cardiovascular disease, stroke, and diabetes, all higher. Interestingly, if you look at the epidemiology of mental health, what you'll find is that there are lower rates of things like major depression, or comparable rates for African Americans when you compare them to whites. What we found in our data, though, was that the use of hospitals for mental health treatment is higher. 121% higher rate of emergency room use, and a 64% higher rate of inpatient hospitalization, which suggests inadequate access to community-based outpatient mental health services, which is a problem across the country, but shows up in a more stark way for the most vulnerable populations. And finally, there's realization that violence has to be treated as the public health problem that it is, and has to be attacked as a public health problem. African Americans have 12 times the homicide death rate of whites in the city of St. Louis and St. Louis County combined. Actually just came from a meeting that the mayor and the police chief called to talk about how the community partners with the police to try and address gun violence. That overwhelmingly impacts African American males 15 to 24 years old in the city of St. Louis. So I told you all of this has an economic impact, right? Those deaths that we said were attributable to poverty and low levels of education have an economic impact of about $4 billion. If just half of those 9th through 12th graders had graduated from high school, they would have made, help me read that slide. How much more in income? $11 million more in income, spent $21 million more on home purchases, added $15 million. Increased the gross regional product by $15 million and added $1.1 million to state and local tax revenues. It's a lot of money that we're leaving on the table by allowing high school dropout to occur at the rates that it does. We spend $1.1 billion on hospital charges associated with heart disease, cancer, and diabetes in St. Louis. Back in the old days, that would build us 3 football stadiums. In a brave new world, that's just 1 football stadium. Eliminating the disparity between whites and African Americans would save $65 million of that $1.1 billion. And even though African Americans make up about 30% of the city of St. Louis and St. Louis County combined, 42% of hospital charges for mental health are for the treatment of African Americans. So closing that gap would save between $25 and $27 million. Significant money, significant impact. If you don't care about the moral story here, if you don't care that people are dying and they don't need to, here's the dollars and cents. Here's what this is costing us as a region. So, it's a lot. There are things we can do. Excuse me. I like to say there's not a whole lot in social science I'm willing to say that the jury is in on. The jury is in on early childhood. We stop doing studies today and know that an investment in high quality early childhood makes sense, works, and gives us a 10% annual return on investment. And I promise you, nobody in this room, year in and year out, in whatever your investments are, is getting 10% every year. It makes sense. So we need to do that for all of our children. We need to help low to moderate income families create economic opportunities. I'm leaving here to go to a meeting about setting up child development accounts for every baby born in the city of St. Louis and St. Louis County. They'd get a $500, 529 college savings account, whether their parents want it or not. Actually, their parents would have to tell us they don't want it. You'd have to opt out of it. As one way of creating economic opportunity. Investing in coordinated school health programs, including school-based health clinics, investing in mental health awareness, screening, treatment, and better data collection, investing in quality neighborhoods. You ought to be able to find a grocery store, a safe place to play, affordable housing, transportation, no matter where you live in the St. Louis region. And then coordinating and expanding chronic and infectious disease prevention and management, which means taking health to where health actually happens, in the communities where we live, learn, work, and play, and creating better connections between clinical settings and communities, in part through a more rigorous and organized use of community health workers. So that's something else we're working on as a region. So in phase 2 of the project, which started around June of 2014, we worked on continuing to inform the public and policymakers, engaging and mobilizing the community around recommendations, which included putting out discussion guides and action toolkits that we rolled out at these community action forums on each of those 6 areas of recommendation. And also, crucially, activating key stakeholders at the leadership level. So we talk about number 2 is grassroots, and number 3 is grass tops, and the need for both if we're going to see meaningful change. And then, of course, being good academics and evaluating our impact. I won't go through this slide by slide, but it was mentioned in the introduction that this was a key resource for the Ferguson Commission. There is a 1-to-1 correlation between our recommendations and the signature calls to action of the Ferguson Commission. And we continue to work closely with Forward Through Ferguson, which is the organization that's taken up the work of the Ferguson Commission. We're working on various strategies that are tied to those 6 areas of recommendation. I can tell you that the furthest we've gotten is on the work that I told you about around universal child development accounts, school-based health clinics. Just got some funding to do some work around coordinated school health. We're going to be putting out another report that's on zoning and land use in the St. Louis region, showing how policies, whether intentionally or unintentionally, segregate both by race and by income parts of the St. Louis region. So we have stakeholder work groups around each one of these strategy areas. I want to talk to you a little bit about what the impact of all of this has been. So one of our goals was to have effective and accessible translation of local data and of research findings and evidence. So we did that through policy briefs, through the report, the discussion guides, and action toolkits, and they're all professionally designed. So we were adamant that this was not going to be the typical academic, I did this in Microsoft Word, I cut and pasted some clip art, and it looks like it. These were all professionally designed by a graphic design firm, and we were very intentional about the fact that they needed to not just have good information, but they needed to look appealing. We also consulted with an agency called Health Literacy Missouri to make sure that our language was accessible, that we were explaining health and other terms in ways that people could understand. And we think it's been successful. There's been, at our website, almost 6,000 policy brief downloads. There are over 1,500 reports in print and another 6,500 that have been downloaded online, 3,700 discussion guide and action toolkit downloads. This is our website, forthesakeofall.org. It's been viewed over 100,000 times by 33,692 visitors in the US and 130 other countries. Really popular in Brazil, and I want to do a personal trip down there to find out why. But that floors me all the time, how much international interest there's been in this work in St. Louis. We're on Twitter. We're doing the social media thing, so we've got Twitter followers and averaging a little over 10,000 impressions every month. That's probably an undercount of how many community and policy engagement meetings we've done, and we've had 132 media reports, mentions, or program appearances. This is a story in U.S. News and World Report on For the Sake of All on the anniversary of the fatal shooting of Michael Brown. We've also begun to influence the policies and systems and practice. As I mentioned, a key resource for the Ferguson Commission Forward Through Ferguson, a collective impact initiative here in St. Louis called Ready by 21 around children and youth development, and our federally designated Promise Zone. We're shaping philanthropic priorities in the region, cited by the city's treasurer in her college kids savings program, and other financial empowerment work. We're coordinating with state agencies around community health workers, school-based health clinics, cited anecdotally, we know, in numerous nonprofit grant applications. And this is cool, I think. I got to go to a school where the preschool class used For the Sake of All to create dioramas of what a healthy St. Louis looks like. I think that's the coolest thing in the world. But the report has been used in curricula from the pre-K to the graduate and professional level. So I was asked to talk about how is this transferable to populations that you all care about? And I think there are some high-level takeaways. And I want to commend two papers that we've put out for your consideration. The first one was in the Annual Review of Public Health with colleagues at Virginia Commonwealth on translating evidence into population health improvement. And we noted that there were really 4 factors that you needed to account for if you were actually going to take evidence about what we know about the social determinants of health and health outcomes and translate that into policy and practice and other decision-making contexts. First, you had to have rigorous science. The data and the evidence have to be accurate and rigorous. But you also have to be strategic in your communication efforts. This is not a one-size-fits-all communication strategy. This is multiple messages to multiple audiences depending on what motivates them. So you notice that we didn't just tell a moral story. We didn't just stand up and say racism. There's economic data in there. There's multiple ways of trying to tell this story to get to the same outcome of equity. You have to understand the decision-making context, and very often that's the policy-making context. Policymakers are not going to read a multi-page peer-reviewed journal article on your issue of choice. They want bullet points, and more importantly, they want to know how what you're talking about affects their constituents. They really want to hear a story about somebody who lives in that district and is impacted by this issue. And then, okay, tell me what you want me to do. Don't explain to me with pie charts and confidence intervals and p-values. Tell me in plain language what it is you want me to do, because I have 100 other things I have to do. So we have to understand the rhythms of these decision-making contexts. And then finally, we have to engage stakeholders early and often. Whoever you want to do something should be at the table as you're planning what you're doing. That's community engagement, that's policymaker engagement, that's nonprofit leadership engagement. It's a lot of work. But that is kind of the broad strategy. We put out another paper that came out late last year, specifically on For the Sake of All, and a process we call civic education. So this is going beyond just informing key decision makers to trying to move some things. And a lot of the emphasis is the same in terms of having strong data and research, and this is influenced by socio-ecological models of health and by evidence-based public health, so that what you're recommending to people has some research and evidence base behind it. And that your strategic communication is driven by accessible language and audience segmentation and the other parts of social marketing that we talk about. And then this stakeholder engagement really understands how the political process works and involves community through community-based participatory research principles. And finally, this notion of coordination and implementation, which is informed by thinking around collective impact and dissemination and implementation science. We think that if you're actually going to get change made, you've got to do all of those things. You can't just do part of it. And the Academy feels most comfortable here. Necessary, but not sufficient. You noticing a theme, pattern? We've got to do all of this in order to make an impact and actually move towards equity. Last thought that I'll leave you with. And it's kind of a sobering thought. So I came up in, my doctoral training's in counseling psychology. And this was in the early 2000s. So multicultural competence was all the rage. That's all anybody want to talk about is multicultural competence. Which is important, crucially important. I've come to the sobering realization, though, that if you don't communicate how what you're talking about for the particular population you're talking about impacts everybody else, politically, you're not going anywhere. Period. It's what's in it for me. How is what you're telling me, what you're talking about, actually going to have some impact on me? Right? That's a very different conversation. That's different from explaining white privilege to people. That's different from showing graphs of disparities alone. That's going to require some sophistication, some nuance, some for the sake of all, right? Not just my particular issue or my particular population. I wish it weren't like that. I wish we cared about each other just as each other. But it seems like, and I'm falling back on some of my colleagues in social psychology in this, unless you can redraw the boundaries of the in-group, you're never going to get that in-group to care about the out-group. That's the learning that I've done. So you've got to redraw that boundary and say, whatever that in-group is all of us. And somehow, and we believe this is true, Policy Link talks about equity being the superior growth model. That's true. We can validate that. If you give everybody opportunity, everybody does better. When everybody does better, everybody does better. Right? We, big we, have been cordoning off resources. And St. Louis is famous for this. I'm told we've got more gated communities and private drives than any other city in the country. Literally walling off resources. And that leads to decline. So we have to begin to make the case that equity actually accrues to the benefit of people who might be resistant to equity. And that doesn't feel good. That doesn't feel like multicultural competence. That doesn't feel like respecting and regarding everyone's differences and the specialness about their background. But to me, that's the political calculation that has to be made. We've got lots of funders and sponsors that I have to acknowledge for the great support that they've given us, and partners as well. Everything I've told you is on our website at forthesakeofall.org, and you can follow us on Twitter at @forthesakeofall. And I got a little time for questions, if there are any. Thank you.